hear us?
Yeah, very well.
We've got Jim Locke, Bharat Dalvi and Gurleen Sharland.
And we are ready with our last...
There's a bit of a time delay. So can you hear us?
Yeah, I'm able to hear you. We are with our last patient for the day today. And it is now close to 8:30 in the night. And I'm very happy to say that the entire team working with me...
Have you had dinner yet?
No, yet to have my dinner. So we have our intensivist, Dr. Srija, my colleague. All the people are geared. Let me show you the case presentation. Dr. Avinash.
The details of case number 7, baby P. He is a 1 year 3 months old boy born by a normal vaginal delivery with an uneventful antenatal and neonatal course. The screening echocardiography done elsewhere during the newborn period identified an abnormal communication from the aortic root to the right atrium. He presented to us at 15 months of age. He is asymptomatic. The examination, his weight was 10 kilograms, pulse rate was 88 per minute, the blood pressure was 110/62 millimeters of mercury, cardiomegaly was present, the first and second heart sounds were normally heard, and there was a grade 2/6 continuous murmur in the right lower sternal border. The chest X-ray revealed cardiomegaly with the cardiothoracic ratio of 60% and pulmonary plethora. The ECG showed normal sinus rhythm at a rate of 105 per minute with a PR interval of 160 milliseconds, normal P waves, QRS duration of 100 milliseconds, QRS axis of plus 75 degree, a QT interval of 300 milliseconds and a corrected QT of 350 milliseconds, prominent LV forces with no ischemic changes. The echocardiography, apical 4-chamber view showing uniform dilatation of all 4 chambers. And here is the apical 5-chamber view with color flow showing the origin of a fistula from the coronary cusp and which courses posteriorly towards the RA and opening into the RA. This is a zoomed view of the apical 5-chamber view with the color flow focusing on the inflow into the RA, showing a dilated pre-terminal portion which is opening into the RA by 2 jets. The parasternal short axis view showing the coronary cameral fistula in its entirety, showing the track from the LMCA and coursing posteriorly, the dilated pre-terminal portion and the final inflow into the RA. The same view with color Doppler showing the origin from the left main and the posterior course of the track, the dilated pre-terminal portion and the inflow into the RA. Color compare mode, same view, focusing on the inflow into the RA. Also the RCA coursing normally is seen. So the plan is for a transcatheter closure of the LMCA to RA fistula. Over to you, sir.
So, Shaq, we can see that there is a fistulous chamber in this child. Behind the aorta, it is a little smaller, but as it reaches its termination, it was looking larger on the echocardiography. Let us see the fluoro live. This is our first picture. So what we did was we took a 5 French arterial axis and a 6 French venous axis, and we took a guiding catheter, a coronary guide catheter. It's a 5 French coronary guide catheter which is into the proximal end of the tunnel, and we can appreciate the left anterior descending and the left circumflex. Circumflex is not dominant, and there is a narrow portion behind the aorta, and then it widens out into a large sac that is in close relation to the right atrium. We could appreciate that this sac was more in the interatrial septal area on the echocardiography. Next picture. So then what we did was we tried a guide wire passage. This is a Terumo guide wire which is coursing across the tunnel.
Shiva, before you carry on, Shiva.
Yeah.
Shiva, before you carry on, at the right atrial end, I know on echo you've shown it, but on the angio, there's a suspicion of 2 exit points.
Yeah.
Is there just 1 or 2?
There are 2 exits even on the echocardiography. There was one sort of superior exit and one inferior
right. Okay.
exit.
I missed that.
Yeah. So we tried with a Terumo wire, we could not succeed because the Terumo wire did not give us support. So this is a Judkins left coronary catheter. Next. So here we tried a coronary wire, but the coronary wire did not pass through. So what we are doing is a fine cross micro catheter. You can see the small dot that is tracking it. So this is a micro catheter that keeps going with the coronary 0.014 floppy guide wire. Next. And then we allowed the guide wire to exit out into the right atrium. And then subsequently next. Then we got it snared. Next. Next. The problem about, next please. We got the snare, but actually we came out through the smaller orifice. There was possibly another orifice also. So we are now through our smaller orifice, and this is not permitting the catheter to cross through. Next picture. So what happened was the catheter that we had from the aortic end was getting stuck at the right atrial exit, but we can appreciate that there is another broader exit a little adjacent to it. Next picture. So then what we did was we advanced the same coronary guide catheter deep inside. Next. So now we realize that there is a narrow portion behind the aorta which is our target where we were going to close, but then there is a redundant sac behind. So we thought of keeping another catheter from the venous side into the sac for putting additional coils in case if there is a continued flow. So right now what we have is two catheters. So there is an arterial catheter which is going from the aorta into the tunnel, and there is a venous catheter that is within the tunnel. I can now show a small injection through the venous.
What is your plan, Shiva?
See, the plan will be to put in a vascular plug, a small AVP4 vascular plug in the narrow portion that is just behind the aorta, almost at the proximal end of the tunnel, so that we are reasonably closer to the coronary.
Okay, Shiva, let me just
but
let me just ask Tin how he would approach this.
I think it's a high risk for losing everything. And so for me, I keep the wire and I use the little bit bigger sheet, marine sheet. Maybe I keep the wire and I can deploy the coil from the venous side. And in case I lose the catheter, and I also remain the AP loop, and I can go again easy.
Jim, any suggestions? Are you comfortable with this?
Yeah, I'm not very happy with this. Can you go back a couple of pictures?
Go back a couple of angiograms.
Yeah, go back. Go back.
I think the sinoatrial node artery is. Coming off.
Yes.
Right there.
Yeah. I think.
Back one.
I think there is a possibility
I think you're right. I think.
Previous.
No, back one.
Previous. Yeah, we are able to see here itself. Next picture. Yeah. You can see a tiny vessel that is coming out. Show the first picture. Yeah, you can see here also. Freeze it.
I'm not worried about myocardial perfusion.
Yeah. Okay, so
but in terms of I think the right atrial sinoatrial artery could be coming off very close to that section behind the aorta.
Okay, so where would you be thinking of closing this fistula?
Let me ask the following question.
Okay,
if you were on the aortic side.
Shiva, hold on. Let Jim make a suggestion.
If you were on the aortic side, okay, and you were past the right atrium, even if your catheter tip was right there, okay, or a little farther in, if you put a 5mm coil, what would happen to that 5mm coil?
Mm-hmm.
It would tumble and close a hole. And then if you put another 5mm coil, it will tumble and close a hole. So as long as you use a coil, and this is an unusual but not an unheard of anatomy, one of the safest ways to close this is to take a coil bigger than any coronary artery around, drop it upstream, and it will plug itself into the fistula's opening. I've probably done that 10 times out of 100.
Okay, so you would go for a coil, Mansoor?
I'm sorry, but I will probably send this patient for surgical closure. At this point, I think Jim's suggestions is bring me the fear that the coils will float there a lot, and then it will thrombose the whole system. So that sinoatrial artery will have the risk of also getting thrombosed.
Well, I will discuss that a little bit later. I cannot find any evidence that surgical closure of one of these fistula is less likely to result in thrombotic propagation than catheter closure.
So, Mansoor, I'm just curious, what on earth would possess you to send this patient for surgery?
Okay, because on surgical, you will see you will see the structures, and your ligations is going to be precise. I mean, obviously now our shortcoming with catheters is that the precision is lost here. So throwing coils or putting a bigger device will jeopardize the flow of the sinoatrial artery.
Is there a surgeon in the audience? Bulos or Hakan? No, they're not here. But what are you going to say?
Jim,
I'll come
my
back to
concern, if you float a coil, it will go into that pouch. But I don't think that it will find that exit to block the fistula. My feeling is, if you are going from the venous side, leaving a lot of loop onto the first putting in 2 or 3 coils in the fistula sac, and then the last loop, if you can leave into the right atrium across the fistula's opening, that may be the way probably to close the fistula. I'm not sure
that would certainly work. There's nothing wrong with doing it that way.
I'm going to pretend to be a surgeon, and if I was a surgeon, I'd be closing this at the right atrial end, and I wouldn't fart around elsewhere, so it would be less precise than you might imagine a surgeon would do. Yeah, pass the microphone back.
It will get thrombus, and it can consider possibility of causing thrombus propagation coronary arteries. So
that
you have
is
to close from both sides, or?
No, that is one thing that can happen. But many times you see that some of these arteries can remodel, especially in smaller kids. And we have seen that a tiny sinoatrial branch can still be maintained if you close the fistula distal to the origin of that branch.
Okay, Warren?
Yes, definitely will close at the waist. I mean, before it's getting more dilated. I'll do it as Shiva said. I probably will go for AVP2 retrogradely at the waist.
Mansoor? Question to Jim. You occlude the exits. Now, dynamics of this sac, pressure-wise, what is it now, and what do you expect it to be after you obliterate the exits? And will that affect the flow to that artery?
So, if you see where this retrograde catheter is here, right? I think you're making a very good point. Me personally, after the holes got closed, or even before, I would fill that sac with metal, and it would be coils. And the reason I would fill that sac with metal after the fistula was closed was exactly the reason. So I'll talk about this later, but one of the late complications of coronary fistula, right, is a coronary artery rupture. And coronary artery ruptures are going to, in this circumstance, is going to follow Laplace's law just like everything else. If the pressure is high and the diameter is big, it's more likely to plug.
So Shiva, my approach, just if I can add my approach to this, would be that I would put either an AVP2 or an AVP4 just beyond the circumflex origin. There is a little waste and then dilatation afterwards. I'd put a AVP2 or AVP4 there, and then on the way, the only thing I'm not comfortable with is your venous catheter being through the smaller opening in the right atrium. I would make sure you could cross into the bigger hole, and then I would deliver either an AVP2 or ADO1 in that region, or you've got a choice of filling the aneurysm with sac. So I would close this fistula at two ends.
And then you would be sacrificing the sinoatrial artery.
Yeah. So what are your thoughts, Shiva?
Yeah, actually, I agree that yeah, this sort of fistula can be aneurysmal dilatation of the sinoatrial artery, and the few twigs that are going towards the sinoatrial node is may get compromised. But in the atrial setting, I think a slow ischemia probably may not result in a significant sinus nodal dysfunction. And even if you put in a coil, and that is going to end up in a complete closure of the fistula over a period of next couple of weeks or so, that also may result in the same sinoatrial nodal ischemia. So at present I won't bother about the sinoatrial nodal artery. I will go with something similar to what Shaq was describing. I'm going to put a smaller plug at the proximal end of the fistula, very close to the circumflex, and then fill up the distal aneurysmal sac with a few coils with my venous catheter that is already lying there.
Yeah, okay. Go on, Bharat.
No, if I would not have seen that artery, Shiva, I would have done what you are saying. But after having seen that artery, if this child were to develop a sick sinus, God forbid, to give him a pacemaker lifelong, is not something. I'm not saying that you will still be able to salvage it, but it would not be my strategy to give up on the sinoatrial nodal artery.
So where
should others have to say.
So where should we close?
Younger child.
Then where should we close?
My feeling is you should close it distal to the origin of the sinoatrial nodal artery.
But,
right. So
but, then,
the
a large sac will be
use
there.
Cursor to show where the.
But then a huge sac will remain.
Yeah. My feeling is that you keep on filling that sac with as many coils as you can, and while coming out from the venous catheter, you plug that hole.
But that, how will we protect the sinoatrial nodal artery? It will thrombose tomorrow.
Yeah.
How will a coil?
Yeah.
A coil is not an incomplete occlusion.
Well,
no?
I agree with not sacrificing the.
Sorry, Mike, go on.
Yes, I agree with not sacrificing the sinoatrial node artery because I had a very bad experience in doing that, and I immediately, I mean, you can see changes on the ECG, and I would not agree. One thing, we do not see the exit points quite. Do you have another projection where we can see where exactly does it open, or the two openings? And then if you can pass another wire, and while you have your catheter in the smaller hole, maybe you can track another wire and can just show us the larger hole.
Okay.
No.
But that's only relevant if you're going to close the right atrial end through the biggest.
The two ends.
Yeah.
First
if
of all,
going to fill the aneurysm, it doesn't matter.
I am not keen on closing the right atrial end at all and leave behind a redundant sac. A sac will thrombose, and the thrombus will keep spreading. So if I have to close this fistula, I have to close it at the proximal end.
Yeah, that's fine.
So right now,
I've got one patient in whom we've done exactly that, but the distal end is still filling from the right atrium. So that aneurysmal portion has remained filling still, it hasn't blocked off. That's about a year later.
Yeah, so what we planned was...
so carry on, Shiva.
So this is an AVP4, 6 millimeters, which is planned to close the... Now show the picture again. See, we are planning to be at the narrowest point of the fistula. So now I am peeling back my right coronary.
So you carry on doing it, but I would have done this from the venous end because you've got better control at delivering the device without encroaching on the circumflex. Because from the retrograde arterial approach, sometimes it jumps very quickly. But you might be okay.
So
Completely in the sac.
Yep.
So fluorostore this and show this again. So now let me make one angiography.
Shiva, just as a question
Yep.
as to why you preferred arterial delivery and not the venous delivery.
See, I mentioned to you
See,
initially
now it's
that
all distorted as well.
I mentioned to you initially that I was not able to cross the fistula because I came out through the smaller exit orifice on the RA. I was not through the larger exit orifice. So right now,
No, but you could have sent the same plug which you have sent through the arterial side, you could have sent from the venous side using the same 4 French catheter.
Can I make a comment here?
Yep. Yeah, Dr. Jim.
I should have said this earlier because I should have said this earlier. What we just learned is that almost certainly we should have seen a right coronary picture before we did anything else.
Yeah.
So if you look at this injection with the plug-in, you're now seeing the right coronary film. And I could be wrong about that branch being a sinoatrial node artery, okay? If you shoot the right, most sinoatrial node arteries come from the right coronary. 55, 45?
55, 45.
Was that right?
No.
Well, I would have just shot the right coronary here.
No, that's 99%.
It's 55, 45.
What view?
Okay.
Well, it could be true. I don't know how to use those devices.
I am
But
surprised.
I do know how to read an angiogram, and I would have shot the right coronary before doing anything. And if this right atrial sinoatrial node artery came from the right,
AB node is 90-10 and SA node is 55-45. At least that's what I remember.
anyhow, that's
Okay. Shiva, can you do an angiogram
right
through the
coronary
venous
picture
catheter?
would have been a good thing to do here.
Yeah. Yeah.
So actually,
Do an angiogram through the venous catheter.
okay.
Okay, so have a look at that. So wherever that branch was, it ain't there now, yeah?
The branch is possibly
And position
distal.
of the plug looks fine.
Yeah. We have got a small redundant sac in front of the plug between the circumflex artery and the plug. But I think to come too proximal will be little riskier. I might pull out into the aorta. So I will.
Well, from this retrograde approach, yes. From the retrograde approach, yes. But if you were doing it from the venous approach, then you've got much more control about locating that plug near the circumflex coronary.
Yeah.
But I think this retrograde approach, you won't have that control.
So through the venous side, now I'm going to put in some
Let
coils.
me make one other comment here.
Yep.
Yeah. So have you released this plug or not?
Shall I release it now? Dr. Jim, shall I release it?
Well, you can keep it there if you like. What's it doing attached now? What role is it playing? Because it's not as if it's going to embolize distally, because it can't go anywhere. So I would release it.
Just a question to Shiva and Jack and everybody, because there are 2 exits here, and then you're going to block 1 exit. And what would you...
Hold on, sorry. Mansoor has changed his mind about that 99%.
I apologize. It's 60-40. You are right, Jim.
Because that's
No,
what
it's
our
40.
That's right. That's what
Give
you
the wire.
In 1%, it comes from aneurysm and stuff. So
No, I
That's
want
different from 99%, isn't it? Warwick, you were saying, sorry, we interrupted.
Just to say that you have 2 exits here, and then you're going to block 1, and what will you do with the next one?
No,
The bigger one.
He's going to fill the
Oh,
aneurysm.
feel that?
yeah. That was the plan.
Okay. So let me make another comment here. I'm now going to say that that's probably not the sinoatrial node artery.
Why have you changed your mind? Mansoor is allowed because he made it 99 to 60.
Well, I'm doing it for a functional reason, and that is that whenever you close a fistula like this, you almost invariably get ST segment changes and ischemia because the contrast carries no oxygen.
Yeah.
So you fill the coronary with contrast, there's no oxygen in it, and you almost invariably get ST segment changes.
Yeah.
And I didn't know this before he closed the fistula, but now that he's closed it and he filled it with contrast, the heart rate didn't fall.
Yeah.
Since the heart rate didn't fall, he's probably okay as far as, now he may get ischemia somewhere else, but the absence of a slowing heart rate, I think, me personally, I think that's very reassuring.
Yeah. So that's not the SA node artery?
No,
I'm guessing it's not.
No, but Jim, he made the angiogram from the venous catheter. It could still
look
be
at this
flowing
angiogram, Bharat. Look at this angiogram.
There is still something flowing, or that's just imagination?
No, there is a
Do a
vessel.
different projection.
There is a vessel that is filling the sinoatrial
Before he
node.
released it, he did a retrograde picture. I don't know where that is. But wherever it is, it's probably not.
Yeah.
You're probably not seeing SA node ischemia because the heart rate would fall when you do that.
Yeah.
At least in my...
So your plug is a little bit into the aneurysm, isn't it? And the other bit is in the dilated feeding vessel.
Yeah, so now I am advancing a coil here.
You might want to pull that retrograde catheter back.
I'm getting a coil. That's softer.
Okay.
Shiva, Jim was suggesting that the aortic catheter be pulled back a little bit.
Well, he'll push it with a coil.
Well, the aortic catheter is now sitting in the aortic valve.
Yeah,
it fell out of the left coronary.
Yeah.
And it's a big vessel, and that's the kind of lack of,
You're holding the
that's the
RCA
kind
tightly.
of catheter with dead space that produces embolic events.
So now what coil have you got?
It's a 8 into 5. It's a 8
My
centimeter.
question is that
8 centimeter long and 5 millimeter.
Diameter. What made you choose that size and length?
I want a more coil mass so that actually, as Dr. Jim was suggesting, if you put in a coil, it's going to keep jumping there, and after the full sac is occluded, then it's going to get closed. So I wanted with 1 or 2 coils.
my question, Shiva, was.
Yeah, another coil. Yeah, tell me.
That looks pretty good to me. Yeah. See how it moved, though? See how it moved?
Yeah.
Yeah, it moved.
Right, it's going to continue to move. Anything you put in is going to drift downstream until you get complete closure. And I don't think that's bad. I think the odds are very high. You're going to put another coil upstream of that, and that may be all you need.
Okay. So Bharat, go
No,
on.
my question was that since you have occluded the proximal entry into the fistula sac, why are you wanting to now fill up the sac? I feel that the sac should collapse once the...
It may collapse, but it can stay patent. I've got an example of that.
If you close it distally, I can understand, Shaq, but if he has closed it proximally,
No.
that sac has
If you close it proximally towards the circumflex, as in this case, leave the aneurysm opening into the right atrium, the right atrium somehow keeps filling that aneurysm.
What has been your experience, Jim? Or you have been always closing the sacs?
I don't always close the sacs, and I'll be honest. You know what, guys? This AVP device is moving as we watch.
Yeah.
If I were, I would look at that. Look at how far it's moved.
Yep.
The
I actually
coils,
think that's a much better position. I think you may be done.
the coils will keep moving.
I think you may be done. I would take a left coronary picture now.
Yeah.
Okay, so why don't you get a selective left coronary angio with a...
So as those coils drifted downstream, they dragged the distal end of the device with them,
What is
which I don't think is a bad thing.
Is that EBU? Get the EBU?
Working.
Is that the EBU?
Oh,
Yeah, flush it.
so, your heparin protocol, Shiva, whilst you're doing planning the next bit?
I am actually going to make, as Dr. Jim was telling, left coronary injection now. I'm going with a coronary guide catheter so that I can give a better injection.
What about heparinization? What do you do?
I have given 100 units per kilogram, and it is yet to be within the first 1 hour.
Okay.
Shiva,
Yeah.
when the fistula was open and when the flow was torrential, guide catheter was a good idea to opacify. But the fistula having got closed, I think even a diagnostic catheter should give you a reasonably good picture. What do you think?
Yeah.
Yeah, I think so. Yeah.
And I think managing the diagnostic catheter is much simpler in a kid of this size rather than a guide catheter.
Okay, I'll do that. So diagnostic catheter, LCA.
He seems to have been persuaded.
That's the boss. That's the boss.
I like being influenced by Dr. Bharat.
Yeah. And just whilst you keep working, but where is your venous catheter? Is it still within the aneurysmal sac or has it popped out?
It has. I think it has popped out. I'm not getting a good backflow.
Yeah. Okay.
Yeah, I think it has come
looks
up.
like it. But yeah.
I'm getting.
Okay.
What is getting? This is not left coronary. Okay, some catheter.
To me, this occlusion system right now looks very good. It's not exactly what was intended. And personally, I always think that an absence of vice in your personal life results in this kind of outcome.
Right, Shiva, you'll have to tell your wife that.
No, I'm just
Clean
getting.
living.
Yeah.
The left coronary catheter that I had taken initially had a flaring of the tip. So I am changing the catheter. Which is contrast. It's a bigger curve.
Whilst they're doing that, any other questions or comments? Yeah. That one's too big a curve, isn't it?
Yeah, unfortunately, Shaq, in India, getting 2.5, 2 is so very difficult.
Oh, okay.
You know, even if you plan, so many times you end up and then shaping them in.
Okay.
But it's quite a tough job to
I am
cannulate
not,
with these kinds of.
No, that's
Be nice
2.5
to
is not giving
It'd
a.
be nice to get a really good angiogram.
Yeah, I'll definitely give it. I will get a EBU 5.
And also a suggestion from Mansoor, who got the percentages wrong earlier on.
Same.
For you to do a right, hands up both. Right coronary angio as well, just for completion.
Yeah, get me a pigtail
I'm
fast.
going to rub this in.
Yeah,
first.
yeah,
Wow.
5 pigtail, 5 cook pigtail. Ravi?
I think this looks terrific. I think it's closed.
Yeah, but
You're filling the right corner. I mean, obviously you want a better picture.
Yeah.
Mostly for aesthetic reasons, but perhaps not clinical reasons. Yeah. It looks very good.
Yeah.
Look at how those coils are dragging that device to the patient's right.
Yeah. And but the nice thing is that they can't go anywhere.
No.
That's my point in using the coil tumbling technique.
Yeah.
It actually works really very well.
Yep.
It's especially useful if you can't, if the course to the right side or to the distal part of the fistula is highly serpentine.
Okay.
If you have a
Having
very
resistance?
serpentine, very convoluted course between the aorta and the right atrium, get as far out as you can and drop a 5 millimeter coil. It won't go to the pulmonary arteries, and it won't occlude a coronary artery.
Yeah. Okay.
One point to Shaq, one point that I couldn't understand, what is the harm, what is the problem with keeping the distal parts of the fistula patent? Is there any harm?
No, there's no harm. The point we were trying to make was that if there is an aneurysmal sac and there is flow in and out, then whether over a period of years, there's thrombosis and microthrombosis and emboli coming up. That's the only thing. But we have no evidence, no data, I don't think, unless, Jim, you have, of those aneurysms at the being
Make a
a problem in the muscle.
I'll show you our data later, but
Ready?
I think it's, for the most part, nice picture.
Yeah.
Let's see that.
Okay, so the right coronary looks good.
And so does it. So the only thing that's on the table is whether or not that branch that came off really very close to the most proximal mark of the device is open or closed, and you may or may not be able to tell with a selective picture.
Get me a 5 French EBU catheter.
But I think this is a good result.
Yeah.
Once again, clean living pays off.
I'll try to give an injection with an EBU guide
Speak
catheter.
for yourself, Shaq.
What's that?
I'll try
Extra backup, guide
backup.
Okay.
new EBU.
Shiva, my this thing was rather than doing it in PA, if we do it in some angulation, at least we'll know whether there is an additional artery going anteriorly.
But once we've got a selective angle, then you can do it in 2 projections,
Since one of the questions that is bothering everyone is whether that was truly a sinoatrial nodal artery.
Dr. Bharat,
if you see a branch going posteriorly towards the sinoatrial node,
I feel that is the sinoatrial nodal artery. In fact, this anatomy is described as a posterior aortico-right atrial tunnel, and the reason for this particular tunnel is enlargement of the sinoatrial nodal artery itself. So it.
Okay.
The sinoatrial nodal artery has collateral circulation?
no, not to the best of my knowledge. But immediate effect, there would be a sinus node dysfunction. That is what even I would expect. The moment the artery stops flowing, there would be some. I do not know whether you can have dual supply to the sinoatrial node. I'm not sure. AV node is described. You can have dual supply, both from the right as well as from the left, but not sure about the SA nodal artery.
Is Karen McCarthy in the audience at all? Okay.
So let's remember the reason that this field stopped, the primary reason that this field stopped doing venous switch operations in transposition of the great vessels was sick sinus syndrome following Mustard and Senning procedures. And let's also remember that the sick sinus syndrome did not occur immediately after surgery. There was a progressive increase in incidence throughout the first 2 decades of life, so that essentially every post-op venous switch had sinus node dysfunction at age 20. So I don't think you can extrapolate from those data, and those were all injuries to the sinus node artery. You can extrapolate from those data that what happens to this kid's sinus node is not completely predictable long term. Yep. You'd like it not to be a short-term event, but it's certainly from that experience it could happen late. If you if you injure the artery or its supply.
And, just to share our experience, without really not being aware of this fact, in the era when we used to close fistulae more distally than proximally, I have 2 cases, similar looking fistulae, wherein in the follow-up angiogram, you can see a tiny little sinoatrial nodal artery because we had closed it at the point of exit. So, but we were not aware. But having been aware, I'm not sure what would have been the best strategy, whether to sacrifice that artery or to retain it.
It's going to require significant catheter skills to engage this left coronary with this catheter.
Yeah.
Unfortunately, I'm not
No,
having
this is going to require skill.
one.
In which case, Mansur, you would lose on both counts.
You're in there now.
Yep, you're in. Excellent.
And then don't pull it out. Do another projection.
Okay. Do LAO?
Shiva, do another projection as well.
Yeah. LAO cranial.
Yeah.
That's a nice picture. I don't see the vessel.
And Shiva, just fluoro it for a longer time. Let's see whether there is any slow flow or anything like that distally going through.
Okay, that's nice. And then could you do one more RAO projection, RAO 30 or thereabout?
RAO? Shaq, but for this transmission, I won't be doing so many angiograms.
Wait a second. What is that there? What is that there, late, on that angiogram, going towards the SVC?
We'll have a look again in a minute.
I thought.
Ooh.
I don't see it.
That's fine, Shiva.
It's probably
Yeah,
flow there.
I think there is a sinus nodal branch.
There's a tiny little branch.
Tiny little.
Yeah. Shaq, I think the child has received a lot of contrast. I think.
Yeah.
I will.
I think so.
I will let you know next year what is the sinus nodal status of this child by possibly doing a Holter.
Yeah, sure.
Yeah, I would like to thank the entire CSI
fair
Frankfurt for giving us this opportunity, and it was a very great occasion. I'll be flying in another 2 hours. I'll be coming towards Frankfurt. I wish to thank all my team members, my
I
staff.
thought you were going to do another case.
No, it's 9 o'clock in the night here. Sister, come here. Come. Actually, I would like to introduce all my team members. He's Dr. Giridhar Gopal, who came from UK, and he's our head intensivist. Our staff nurse, Dr. Srija, Sister Tereziamma, Mr. Prabhu, the technician, and we really enjoy these interactions that happen when we do these transmissions to Frankfurt and other similar conferences. And I thank a lot for all the audience for staying till now there.
Well, it's earlier than it is for you, isn't it?
And,
it's still afternoon
and
here.
we must thank you, Shiva, for sharing such wonderful cases with us and for doing such a great job. Thank you so much.
Thank you.
Shiva,
Yeah.
Shiva, get your team, give them some food to eat as well, and then have a safe flight, because you'll get some food on the flight anyway.
Yeah.
So have a safe flight to Frankfurt, and we'll see you here tomorrow.
Yeah, tomorrow
well
morning.
done to the whole team and all the bosses over there, the ladies in particular.
Yeah,
Big hand for them once more.
Thank you very much.